hearing innovative ideas about how to engage in the pandemic. I'm motivated when I see my approach is not working in that for their needs, knowing that's going to make a difference, listening more about people's stories, my motivation to learn everything I can do to make my work better. It's fine if you don't have a microphone, you can chat. Feedback from clients and cases. I like to learn how other people are working with people that make changes. Transparency is something that helps. Learning new approaches and new techniques. Ensuring the best health for people. Seeing that my team is trying new techniques and testing them. Realizing the impact that we're making. Great. Evidence, the research around it. So wonderful. So those are great things. And I'm hoping, again, I'm seeing some more stuff. So great. My motivation is when I work directly with participants is to make sure that they are heard and seen. Appreciation from a patient, seeing my impact from my knowledge on others, witnessing somebody using an interesting approach helps, building relationships, how to pivot when working in this virtual space. Thank you for saying that. I'm going to end on that because we had a pivot. We're pivoting too. We just saw a beautiful dog. We're pivoting right now by all of the things that we're having to do in making those adjustments in the virtual world. And I so appreciate that, that you're willing to do that with us. I'm going to now turn this back over to Pike, who's then going to have us move towards the opening presentation. Thank you so much.
Yeah, thank you everyone again for bearing with our technical issues, but again, we're just so happy to have you here. I will just give a quick plug for the app. It's the Whova app. If you haven't downloaded it, that can also be a good opportunity to chat and connect with your fellow participants, which I know is one of the best things about going to a conference. But that being aside, I'm gonna now bring on, you probably remember Linda if you were here on Friday. Linda DeSantis is the main organizer for this entire beautiful event. And she was able to secure our wonderful speaker. So I'm gonna turn it over to Linda, who can tell you a little bit more about Dr. Blackstock.
Thank you, Pike. And yes, I have to say, good morning, everyone. It's so nice to see familiar faces and see you all back again since our Friday, day one. So welcome. And I really am very excited to introduce our speaker today, Dr. Oni Blackstock. As Pike mentioned, I secured this. I've heard her speak on several occasions. She's very sought after, and I'm just excited that she's here today. So let me tell you a little bit about her. Dr. Blackstock is recognized as a thought leader and influencer in the areas of HIV, health equity, and racial justice. She is the founder and executive director of Health Justice, a consulting firm providing content expertise in HIV, sexual health, LGBTQ health and racial equity, to public health and healthcare organizations. She is a primary care and HIV doctor and researcher who sees patients at Harlem Hospital. Dr. Blackstock recently served as Assistant Commissioner for the New York City Health Department's Bureau of HIV, where she led the city's response to the HIV epidemic. She received her undergraduate and her medical degrees from Harvard and completed her primary care internal medicine residency and ambulatory chief residency, Montefiore Einstein, as well as an HIV clinical fellowship at Harlem Hospital. She received a Master's of Health Sciences research from Yale School of Medicine's Robert Wood Johnson Clinical Scholars Program. She's a very sought after speaker, and it is with great honor and privilege that I get to introduce Dr. Blackstock. So welcome.
Thank you so much. Thank you for the introduction, Linda, and thank you to Linda and her team for being so amazing. My PowerPoint, for some reason, decided not to work this morning, as well as my other word processing stuff. So they were great in getting this together. And I also want to thank all of you, disease intervention specialists, for all of the work that you're doing, ending the epidemic. Okay, so I'm going to basically say next slide, because I don't have controls of the slide. So just in terms of learning objectives, so after this talk, you'll be able to define medical mistrust, characterize the relationship between medical mistrust and health outcomes, understand the historical factors that have contributed to medical mistrust in the Black community, and then lastly, identify approaches to addressing medical mistrust with clients and patients. Okay, next slide, please. Okay, so again, the presentation roadmap is similar to that, giving an overview, talk about the origins, talk a bit about provider bias and some potential approaches then to addressing medical mistrust. Next slide. Okay, great, next slide. Okay, great, so just to start with like a case vignette, you call a client to do a partner notification. However, you notice that your client doesn't sound well and they say they're having fever, cough, and difficulty breathing. You're worried that they may have COVID-19. You tell them you think they need to go to the emergency department nearest them, but they say, you know, I don't trust that hospital to take care of me. The staff there haven't treated me well in the past. I'd rather go home until I really have to go. So we see medical mistrust showing up in many ways. I'll give some examples related to HIV during the presentation. Next slide. Okay, so what is medical mistrust? So medical mistrust is not just a lack of trust in the medical system. So when I say medical system, I mean hospitals, providers, treatments, and that also extends to government actually and the pharmaceutical industry. So not only a lack of trust in the medical system, but the belief that the medical system is acting or will act with ill intent towards a certain individual or group, and typically a marginalized group. Next slide. So medical mistrust is it's also considered an active response to direct or vicarious marginalization. So vicarious meaning could be, you know, stories or narratives or experiences that have been passed down over the generations, or also stories that people share within their social networks, within their communities. Next slide. And it's also defined as a phenomenon created by and existing within a system that creates and sustains and reinforces a number of systems of oppression, including racism, classism, homophobia, transphobia, and stigma. And it can be also referred to as inequality-driven mistrust. And this is notably different from some of the mistrust we see with, for instance, the anti-vaxxer movement. This is a different type of mistrust that I'm talking about today. Okay, next bullet. Okay, and medical mistrust is often sort of contextualized in a more sort of pejorative or negative way, but actually it's an appropriate survival mechanism that often allows people to protect themselves or at least prepare countermeasures. So, you know, if a patient is feeling, you know, concerned about, you know, going to a healthcare provider, they might prepare by, you know, writing down a list of their concerns, making sure they've read up on whatever the issues are, maybe bringing a family member with them. It's also a form of resilience and a way for people from marginalized groups to empower themselves. And so we often hear of the term like conspiracy theories, which again also has a negative connotation. So I often prefer, and many people prefer, to use counter narratives. And these are narratives that arise from really the vantage point of persons from groups that are historically marginalized, and is often justified and based on reality and real experiences. Okay, next slide. Okay, so medical mistrust in terms of HIV, there are two sort of main buckets of beliefs related to mistrust. One are quote unquote conspiracy related beliefs. So the idea that the government created HIV as a form of genocide against people of color, in particular Black people. And then treatment related beliefs, the idea that HIV treatment itself is used to experiment on or kill those who take it, or that a cure is available but is being withheld by the government and or pharmaceutical companies for profit. Next slide. So HIV counter-narratives or beliefs are relatively prevalent. So this is data from the National Survey of HIV in the Black community. And this shows that, for instance, you know, about 31% of people believe that HIV, at least in this survey, that HIV is a man-made virus. About 40% believe there's a cure, but the government is withholding it from marginalized people. A third believe that the medicine that doctors prescribe to treat HIV is poison. And then almost 1 in 5 believe the government usually tells the truth about major health issues. So very small proportion believe the government to be truthful when it relates to healthcare. Okay, next slide, please. And then we're seeing these concerns, this medical mistrust evidenced in concerns around COVID-19, the origins and vaccines. I just included 2 tweets here. One is my own that I tweeted because I live in Harlem, and I was walking down the block and I heard this older Black man say, you know, about COVID-19, it's man-made, they already have a vaccine for it. I really thought it was important to hold space for, you know, counter narratives that are obviously based on historical realities and current truths, and that there are aspects of the COVID pandemic that are man-made. This is another tweet that says, folks, I've polled Black people and I suspect that they will not be taking the vaccine for COVID once it becomes available. When asked for their reason, they mentioned Henrietta Lacks, the Tuskegee experiment, Monday, Tuesday in the US. Thought I'd inform you. Okay, next slide, please. And this is just a number of headlines that also speak to the concerns that people have. Nearly 1/3 of Americans believe a conspiracy theory about the origins of the coronavirus.
Dr. Blackstock, can I interrupt you 1 second?
Yes.
Can I ask everybody to please mute your phone? Someone's phone is providing a lot of background noise. I believe it's a 408 number. Anybody? Okay, sorry, go ahead. We'll try and get that solved. There we go, got it.
Okay, great. This other headline, you know, speaks to Tuskegee, which I'll touch on a bit, looming in the minds of some Black Americans in terms of whether their willingness to get a vaccine, and 1/3 of Americans believe a coronavirus vaccine exists and being withheld. So, you know, medical mistrust exists in many contexts, including HIV and COVID-19. Next slide, please. Okay, I think I have a number of animations, Greg, so just be ready. I'll be saying next slide. So this is just a slide showing sort of, it's very busy, but really showing how medical mistrust might impact one's overall health. So next click. Okay, great. So it sort of starts with basic causes, which include racism, sexism, discrimination. Next click. And those impact obviously one's, for instance, marginalized status in society. Next click. And those can also result in sort of transmission, cultural transmission of ideas and worries. So medical mistrust, as I mentioned, might be something that either is based on someone's actual personal experiences of people in their community, or experiences of others and generations before them in their community. Next click. And the responses to the medical mistrust can then be behavioral, where you see it impacting satisfaction with the level of care people have, treatment adherence, cancer screenings. Next click. And all of that ultimately affecting, you know, morbidities such as HIV viral load, mortality, disability, mental health. Okay, next click. Okay, great. So medical mistrust impacts a number of health behaviors. We see associations between medical mistrust and lower healthcare utilization, including preventive health practices such as cancer screenings. We see lower adherence to medical treatment, and I'll speak specifically to HIV treatment, poor quality patient-provider relationships. Also a higher likelihood of engaging in behaviors that place that individual, you know, at risk, for instance, acquiring HIV, and also lower rates of involvement in biomedical research. So HIV vaccine trials, COVID-19 vaccine trials. Next slide. So we also know specifically related to HIV, it's also negatively associated with the number of outcomes we see in terms of prevention, medical mistrust associated with lower uptake of HIV testing, lower uptake of condoms, less comfort talking with your provider about PrEP, and also lower awareness and uptake of PrEP. And then next click. And then we also see it among, if someone is living with HIV, a lower likelihood that they believe that HIV treatment is effective. They will be less likely to adhere to medications, and as a result, a lower likelihood of viral suppression. And then there's this question of whether medical mistrust is also associated with less engagement in care. Next slide. So just to address that last point, there was a recent study, I guess from 2 years ago, by Dr. Jessica Jaiswal, who's done a great deal of work in medical mistrust in the context of HIV. And she did a qualitative study where the researchers did really like sort of wide-ranging interviews with patients who were living with HIV, who were in different stages of HIV care engagement. The majority of the participants were Black. And what she found was that HIV-related beliefs are common. So some of the the conspiracy-related beliefs and treatment beliefs that I mentioned before are common, but may not necessarily be a barrier to care. Participants in different stages of engagement in this study insisted that these beliefs, even though they were common, didn't play a central role in how they managed their health. And so this is a quote, I do, but I don't in terms of thinking these beliefs impact their own engagement in care. I think they experiment with a lot of stuff and things happen and the stuff just starts forming. I can't be thinking about all those other beliefs. I got other stuff to think about. So people were really focused on their own care. And even though they did have these other beliefs, they kind of pushed them to the side. Next slide. Okay, now I'm going to just give some background about medical mistrust with a particular focus on the Black community, just because there is a very long legacy of medical experimentation and really just human rights violations that really inform and have informed for generations the interaction that people have with public health, Black people have with public health and the healthcare system, and don't want to take any attention away from current realities, but the focus will be on historic, the legacy. Okay, next slide. Okay, so, and I should also say that I will also focus primarily on the role of physicians that in medical experimentation. Unfortunately, there's less data available for nursing, although I'm sure the sources exist. The ones that were readily available to me were focused on physicians. So just beginning back when we think about medical practice during the transatlantic slave trade, it was often actually referred to as a very much medically managed enterprise. And that's because doctors were really responsible for inspecting enslaved people before they were forcibly taken onto slave ships. And they were also hired to ensure that enslaved people remained alive and healthy during transport. And they were compensated with money as well as more enslaved people if they were able to keep people alive during that harrowing journey. There's also an act called the Dolben Act, also called the Slave Carrying Bill, that in 1788 then mandated that all slave ships, at least that were run by sort of English enterprises, that those have a doctor on board. So it's sort of codified this role of the medical provider in the slave trade. Next slide, please. So this is just like an advertisement that really speaks to like how important it supposedly was to keep people alive. It says to be sold on board the ship, a choice of cargo, 250 healthy Negroes just arrived from the windward rice coast. The utmost care has already been taken and shall be continued to keep them free of being infected with smallpox. No boat having been on board and other communication with people from Charlestown prevented. So really just speaking, and physicians often played an important role in this way. And then this other quote just really speaks to the role that physicians played and how important it was to keep folks alive on the slave ships, which obviously was in direct contrast to the way people were being treated. Okay, next slide, please. Also occurring during this time as the slave trade was growing was this sort of the birth of the idea of the construct of race, and that evolved in the 18th century during a time where there was really increased awareness about animal subspecies as a result of animal breeding. And so there sort of were different categorizations made where people of African descent were categorized as Homo sapien affer, and affer means sort of ruled by caprice or whim, not logic. And so this categorization was associated with really a hierarchy of humanity where Black people were considered innately inferior. And this was reified by what Europeans said were biological differences in terms of physical and mental defects of Black people. So there's the study of phrenology, which you can see the picture on the slide, in terms of cranium size and the implications for that in terms of sort of one's intellect. There were also conditions that were quote unquote discovered. So drapetomania was a condition of actually enslaved people trying to run away from their owners that was actually pathologized and made into a condition called drapetomania. Hebetude was another condition that was only sort of relevant in terms of for Black people and was characterized by laziness. And then there was also this belief that syphilis in particular had different manifestations. And I mention this because it has implications for the Tuskegee experiment. It's the foundation of why it happened. There was a belief that syphilis did not impact the nervous system of Black people in the way that it impacted the nervous system of white people, because it was thought that Black people had a less developed nervous system, and so that their manifestations of syphilis were more heart or cardiac related, and for white people is more nervous system related, and that was really the basis of the Tuskegee experiment. Next slide, please. Okay, and then medical practice during slavery, again, was a partnership between doctor and slave owner, where doctors played a key role in establishing the soundness at the auction block, where if an enslaved person became ill or died, it was really considered a financial loss for the owner. And so because enslaved people were often hospitalized at their owner's expense, owners did what they could to avoid professional medical care. Next slide. And so the care of enslaved people when they were sick was first attended to by other enslaved people who often used more acceptable traditional methods that were passed down over the generations. Because often enslaved individuals wanted to avoid other harsh treatments from their owners, such as like lancing, where people were like bled out, purging, just really very painful quote unquote treatments. Then if those didn't work, then a physician was called, and if they weren't able to help, then the enslaved person was often admitted to a poorly resourced slave hospital, which was often a place of experimentation. Just to say, Black midwives, just if there are any folks in the audience who are great supporters of midwives, that most plantations designated women who attended births, both enslaved women and slave owners, wives and mistresses alike, as well as caring for babies and children. They had a very central role in the care of women and babies during that time. Next slide. So I think one case that is particularly notorious is the case of Dr. J. Marion Sims, who's known as the father of modern gynecology. He founded the New York Women's Hospital. He actually owned enslaved people that he then did experiments on, obviously without their consent and without anesthesia. He also conducted surgical experimentation on babies to learn more about newborn tetanus. And he is most well known basically for developing and refining repair of vesicovaginal fistulas, which is a condition that happens during traumatic childbirth. And he practiced this procedure on enslaved women that he owned, and did it again without pain medication. And then later, once it was refined and perfected, then used the technique on obviously consenting white women. That is a picture of a statue of him that was across from the New York Academy of Medicine by Central Park that was taken down within the past year or two. Next slide, please. Okay, and then just to say, even after Black people died, there was a traumatic abuse by the medical establishment. In particular, as medical schools were popping up during the 1800s throughout the country, there was like a frenzied need for bodies to practice anatomy and other surgical procedures. And so this made Black and poor white people really wary about going to the hospitals, because they were concerned that they would be unnecessarily experimented on or allowed to die so that they could be practiced upon. And so this practice of grave robbing began, and a worry about the night doctors emerged, where it's the folks in that picture there, where people, usually white people, come to a Black person's home to take them, and so that they can then be used for medical experimentation. bodies were really shipped from the south to the north. There's schools such as Harvard Med School, where I attended, that used this dissecting material. Next slide, please. And I just want to just show some pictures, but I want to just say this is a content warning for the next 4 slides. These are images from a documentary called Until the Well Runs Dry, Medicine and the Exploitation of Black Bodies by Dr. Sean Utsi. And it gives examples of the ways in which Black people's bodies were used in anatomy classes in the Medical College of Virginia. And it's very interesting. With that medical school, they actually found, they were excavating an area to build a new building for the medical school, and found all of these remains, and they ended up being the remains of many of the Black people whose bodies were used for anatomy class. But all of them had been stolen from graves. Next slide. So this is just a picture, you know, of a dissection of anatomy class with professor and students dissecting a Black body for anatomy class. Next slide. Again, more pictures. Next slide. Next slide. And this one especially very gruesome. Next slide. So just people should know that beliefs around grave robbing and the use of Black bodies and medical experimentation are widespread and have been sort of passed down for many over the generations. So just to say also, during this time, hospitals were segregated, so there was separate and unequal care. Up until the 1960s, hospitals were rigidly segregated by race. In the South, there were very few healthcare facilities where Black people could go, so they would often have to wait very long amounts of time. If they were seen, they had to wait after white patients were seen, and then often relegated to beds in the hallways or basements of white hospitals, and often receiving care in these hospitals, if it were a segregated hospital, would be contingent on consenting to being experimented on. So in order to get care, you had to consent to be experimented on. Next slide. Okay, and just to say, I think it's just like important that at the same time, because there weren't places for Black people to receive healthcare in a way that was safe and high quality, the Freedmen's Hospital was established. That later became Howard University Hospital, and the medical division of the Freedmen's Bureau then led to the development of the Black hospital movement, where about 90 new hospitals for Black people were erected throughout the US, and it really represented the move from exclusion to segregation in hospital care. Next slide. Okay, and this is just, I think, may not be completely relevant, but I think just important for people to know that when we think of like desegregation, for instance, of schools, of neighborhoods, you know, usually that was associated with, you know, loud protests, very, you know, you can see the visuals of little Black children entering schools. You know, for hospitals, it was actually happened much more quietly, and it happened with passage of the Medicare program. The hospitals could receive Medicare funding, so funding for older people or people who are disabled, only if they integrated, if they had all types of patients of all races. And so the Johnson administration's Office of Equal Health Opportunity was a very small office, 5 staff, but so many people were committed to this goal of integrating hospitals that 1,000 employees from federal agencies volunteered, and about 10,000 civil rights organizers on the ground actually became inspectors who really fanned out across the country to hospitals to make sure there was compliance with the law. Next slide. Okay, and just to say again, Tuskegee is known officially as the study of untreated syphilis in the Negro male, and just to say that you know, this study was about the fact that men did not know they were in a study, and that, you know, syphilis treatment, even prior to penicillin, there were other treatments that were being used, that all measures were taken to prevent the people, the quote unquote participants of the study, from accessing any type of care, for any type of care actually, but particularly for syphilis. So if it was heard that they were going to a nearby clinic, if they went to another town, people from the public health service, but actually officials, would show up and tell them that they could not get care here. They were actually denied entry into the military because there was fear that they would actually receive treatment for their syphilis. So penicillin became approved in 1945, and shortly after that, there were rapid treatment centers for syphilis set up all over the country, but the quote-unquote participants in the study were barred from getting care there. And it wasn't until 1972, when there were finally news reports about what was happening, that the study was shut down. And as a result of that, institutional review boards, so the National Research Act in 1974, that established institutional review boards to ensure human subjects protection. There was similar study of Guatemalan prison inmates and psychiatric patients as well. And then someone asked about Henrietta Lacks, her cervical cancer cells, which were taken from her without her consent. Those have been used in a wide range of studies and are still being used for countless medical advances have been a result of that. There were also the pill studies in Puerto Rico, which people may know about, where Puerto Rican women were enrolled unknowingly in studies of the contraceptive pill. And as I mentioned, 1974 IRBs were approved in response to the fallout from Tuskegee. Next slide. And I'll try to move along a little faster. So just to say eugenics, which I think people have heard about in the news in regards to Irwin Detention Center, just to know that there's a long history of this idea of sterilizing, forcing sterilization of people in communities that are deemed unfit. The North Carolina Eugenics Commission sterilized about 8,000 mentally disabled people through the 1930s, about 5,000 were Black. And the Southern Poverty Law Center estimates about 100 to 150,000 women were forcibly sterilized, the majority of whom were Black. And many of these sterilizations actually happened outside of the law at the discretion of the physicians. So, you know, a physician, so Fannie Lou Hamer, who was a famous civil rights activist, she went to have a minor procedure done and then ended up waking up without her uterus. And it's called a Mississippi appendectomy. That's the name of it. Okay, next slide. I think I'm running. And just to say that, you know, this all continues today. Next slide. I'm actually just gonna, next slide, and next slide. I think I may be running a little out of time, but just to say that most of this can be read about in Harriet Washington's really powerful Medical Apartheid. And I think anyone who is involved in healthcare, public health should read this book. Next slide. Okay, and so next slide. So just in terms of provider, so just to say that that is all, you know, and that's just scratching the surface. So some people may be familiar with this, some of this history. And then patients and clients are also dealing with provider bias. So thinking about implicit bias, it refers to attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. And it's thought to be activated involuntarily and without an individual's awareness or intention control. Regardless if it's implicit or explicit, it has the same impact, which is important. It's considered different from explicit biases and are thought to form from very early sort of age and exposure. And there are real concerns about its impact on health outcomes. Next slide. And so just to say, there was a systematic review done of studies looking at healthcare professionals, examining the association between implicit bias and healthcare outcomes. And they found low to moderate levels of racial ethnic bias among, so it's asking, the name of the book is Medical Apartheid. Found low to moderate levels of racial ethnic bias among healthcare providers. The scores were similar to the general population, so similar levels of bias among healthcare providers as compared to general population, and the levels of implicit bias against Black, Latinx, and dark-skinned individuals was relatively similar across groups. Next slide. And so results show trends towards implicit bias being significantly and negatively associated with patient-provider interactions. So providers who have more implicit bias towards that patient have more dominant communication styles, so they'll talk over the patient or client. Treatment decisions, we know that Black patients are less likely to be provided appropriate pain treatment when a provider has implicit bias. Treatment adherence, Black patients of pro-white bias providers were less likely to fill their scripts, and then patient health outcomes, Black patients reporting worse psychosocial outcomes when they're cared for by providers who have implicit bias. Next slide. And just to speak quickly to pain treatment, as I mentioned, Black people are less likely to receive pain treatment. If they do receive it, the amount and quantity is lower than that received by white people. And there's just highlighting a study showing when individuals, white and Black, went into emergency department to receive pain medication for extremity fractures in the ER, there was a difference. 57% of Black patients received pain treatment versus 74% of white patients, despite having a similar level of pain. And then this is not limited to adults, to grown-ups. In a study of appendicitis among children, Black patients received opioid pain treatment significantly less frequently than white patients, 12% versus 33%. And if you Google "Until the Well Runs Dry," you can find a link to a video of it. Next slide. Okay, and just to quickly say, there's lots of study of false beliefs and biological differences between Black and white people. So some of the beliefs that people have, for instance, are that Black people's nerve endings are less sensitive than white people's. Whites have larger brains. And a study found that 14 to 58% of white people in this particular study endorsed false beliefs about Black people, with as many as 60% of white people believing that Black people's skin is thicker than whites. And these false beliefs were actually associated with lower ratings of pain. So thinking that like someone's skin was thicker made you think that they actually had less pain than a comparable report in a white person. Next slide. Okay, great. So, there's all that context. There's a legacy of mistrust. There's clear evidence around bias and how that impacts health outcomes. And so now I'll just touch on some approaches to addressing the mistrust that clients and patients understandably have. Next slide. Okay. And so I think you're going to be doing motivational interviewing session after this, but just to say, there really is a lack of evidence-based interventions to address medical mistrust, including in HIV and STI work. And so the recommendation is, to be patient-centered. So ask open-ended questions about patients' beliefs, including those related to medications. And asking open-ended questions can be really helpful because it really shows the client that you care about them in a holistic way, and that you want to fully hear all of their concerns. Also, recognizing signs of medical mistrust is important. So that could look like lack of eye contact, a patient or client who's not answering questions. Sometimes clients will just say, I don't trust these medications. So that's like very clear, and you can address that and we can talk about that. Or when patients may be not coming to visits or non-adherent, that may reflect some level of medical mistrust. And so what's important to do is really to validate patients' concerns or mistrust that they exhibit. And part of that is really acknowledging historical and current realities that may have led that person to be mistrustful, including their own experiences. And then asking for permission to share information after validating their concerns. And so what's really important, so part of validating is saying that, recognizing that the client's thoughts are really well-grounded, they're justifiable, they're relevant, and they're meaningful, and it's also showing empathy. And it could sound something like this, given, for instance, Black people's experience with racism that they face or have faced, it makes sense to believe that providers, may not be looking out for your best interests. And there's so many examples, in Tuskegee, et cetera, in the past and the present of, Black people not being treated well, for instance, in healthcare. So it's understandable to be cautious with healthcare providers and to understand or to wonder how, for instance, your medications might work. Totally understandable. And so in terms of asking for permission, it may sound like, so after the person tells you how they're feeling, so it sounds like you don't trust HIV treatment. Would it be okay if I share with you some information about treatment and you can tell me what you think? So really just getting their permission and then giving them space to tell you what they think of what you've shared with them. Next slide, please. Okay, and then also using motivational interviewing techniques, which I think you will all be doing more of after this. And that includes expressing empathy through reflective listening, sort of like saying back what you're hearing, what you hear that person is saying. rolling with resistance, so avoiding argument and direct confrontation. Like, don't say something like, if a person's like, I don't trust these medications, like being like, well, no, you should trust them. The medications work, not to do that. Adjust to client-patient resistance rather than opposing it, and supporting self-efficacy and optimism. So sometimes patients, may want to use their own treatments or herbs or whatever, and as long as they're not harmful or going to interact, like, it's great to say, that's so wonderful that you're doing something to try to stay healthy. Let me share this other information with you as well, and maybe you can use those strategies together. Next slide. The next slide. Next, yes, thank you. And so also just the patient-centered approach is also, understanding from the patient what their priorities are related to their health, where you're treating, if it's HIV or STIs or whatever it is, sort of what that hierarchy of concerns are. Again, related to that, understanding their competing priorities and concerns, and then utilizing shared decision-making. So really talking about, what are the benefits, risks, and alternatives to a certain treatment or a certain approach, and then really understanding what their preferences and values are, and together, collaboratively, making a decision about whatever the treatment plan is. Next. Okay, great. And then also just, I think in terms of medical mistrust in general, I think longitudinal anti-racism training for public health and healthcare professionals, and in particular leadership, is really important. And that includes education about historical and current factors that contribute to medical mistrust and how mistrust impacts health outcomes. Next slide. So I think I just have 2 more slides. So really quickly, this is just a list of just some examples of questions also that you can ask your client. So for instance, I don't want to assume anything about your identities. How do you identify racially, ethnically, culturally? What are your pronouns? Many of my patients experience racism in healthcare. Are there any experiences you'd like to share with me? What have your experiences been? Have there been any experience that caused you to lose trust in the healthcare system? So this is a list of questions from the Southern Jamaica Plain Health Center. I think the slides will be sent out today so you can actually see all of them. And it's really about focusing not on what's the matter with the patient, but what matters to the patient. Next slide. And then lastly, there should be systems level approaches. So making sure that have staff that reflects the patient or client population, particularly increasing underrepresented group representation among public health and healthcare workers. Using community workers or peer navigators have been shown to help with reducing mistrust in other settings. Working with faith-based organizations and community-based organizations to really understand what are the needs in the community, and then a commitment. We've got a commitment to work towards becoming a fully inclusive anti-racist organization, whether it's a public health department or a clinic. Next slide. Okay, great. And I think that's everything. There's a lot of, noise in the background here, but happy to take questions if there's time.
Great. Thank you so much, Dr. Blackstock. This bringing this historical perspective, this understanding really can impact the work that people do. And so there was a lot of response about people relating to this with their family who are not trusting providers. And I do have a few questions. The correlations you're providing about medical mistrust and HIV-related health outcomes, are they specifically about medical mistrust in the US or in other parts of the world as well?
Okay, yeah, that's a great question. Yeah, so these studies that I pointed out were specifically around medical mistrust here in the United States.
Okay.
And just to say, I think specifically related to, because of all of what I showed you in terms of the origins and the roots of it, I think there's just been ample research around mistrust in the US.
Yeah, I mean, those perspectives and, the exclusion to segregation, I just found this perspective so important, to be honest. And really, I would ask my colleagues if I know we had a question about the Henrietta Lacks cells, if they're still being used.
Yes. Yeah, those are definitely still being used. Yeah. And I don't know if people, there's her family actually now has an organization where they are really sort of advocating for, to prevent something like this happening, because for several decades, they didn't even know that her cells had been taken and were being used for scientific research and advances. So their work has been really important as well in terms of just advocating for greater transparency in research.
And there were people, I think Anshe had a hand raised. I don't know if that was for a question. And there was also people just saying they have so many family members who are afraid to visit a hospital or see a doctor. They fear being misdiagnosed, or having their lives put at risk. And so really this history is long overdue. Again, just reading through the comments. But I would ask Anshe, since I saw a hand raised, if that was a specific question.
Hey, yeah, it was a specific question, and thank you so much for this presentation. I really enjoyed it. I do want to ask, in regards to what Linda just stated, right, in regards to some of the comments that folks asked around their family members who are having that experience in regards to going to a doctor or adhering to checkups and those things. What support do you have for many of us in this workforce who are the work, but also doing the work, so that we can best support our family members or those who we are within our networks, right? I think COVID is bringing up a lot of the medical mistrust, and a lot of my family members are not adhering to it, some of the mandates. And, someone who's wanting to be near family that, I want to be there, but I'm trying to adhere to the mandates, but there's a part of me want to feel belong to. And so what do we do to support each other around that?
No, I hear you. I think a lot of, am I still muted or no?
No.
You can hear me? Okay. Yeah, no, I think that's like a really challenging situation that I think, as you're saying, many of us deal with. I think part of it, honestly, I think the motivational interviewing techniques, which I'm sure you probably have expertise in, which more people will be doing, I think it's actually really important to use these in our interactions with our family members. And so I think, even things like, what would it take you, for instance, to wear a mask? And it may be person doesn't want to wear a mask everywhere, but maybe you could do a conversation and really sort of understanding what their concerns are, what their preferences are, figuring out maybe they would just wear it, in this setting, but maybe not that setting. Because I think a lot of it's also about just harm reduction too, or just meeting people where they are. Because as you mentioned, a lot of people do have concerns that are very, you're right, that are justifiable and really based in real life experiences. And so I think the point is not to get people to change their mind completely, but really work with them to figure out just given what their beliefs are, what information you share with them, how can you sort of move someone even incrementally. So I would say even just using some of the MI techniques that you use. And I think, and just to say, this may not be related, but who were asking about family members and mistrust of healthcare providers. So I think one big thing is, obviously doing research before you go see a healthcare provider, if you can, understanding the patient bill of rights for that organization. And then also bringing someone with you. I think that can be really powerful. And just the way that for instance, peer navigators and community health workers work, having a family member with you can also advocate for you and let you know that whatever you are experiencing isn't in your head, can also be helpful.
Yeah, somebody else just commented that they're wondering if years from now we learn that Latinx people detained in the US detention centers may have experienced similar atrocities.
Yes, definitely.
So just, those comments. And people are, again, acknowledging harm reduction, taking a more sensitive approach to mask the debate and try to come from a place of empathy. And I, really appreciate the strategies that you described and mentioned and the examples of how to validate and how to ask permission. I know that your time is limited, so I didn't know. I have more time if needed. Well, people are singing your accolades. I think this is a presentation that's long overdue for many of us, but your slides will be available. And then there is a question about, do you know of any resources for organizations who want to embrace anti-racism?
Yes, I do. And I have a whole presentation on that too. Wasn't sure how much to put in here. My question though is, are they going? Is there? Can I send you the link and that can be sent out to?
Yes, please send it to.
Okay, but yes, but just to say, Race Forward. If you look up Race Forward, that organization, and I believe it may be called racialequitytools.org. There's like tons of information on that website, that organization's website. So Race Forward, just Google that organization, and I believe Racial Equity Tools. And that website has a wealth of information about what to do if you're an organization that's interested in, upholding racial equity or moving towards becoming a more inclusive and equitable organization.
Yeah, and I would ask my colleagues, Greg, you're sharing your inbox. Take that down. But I would ask any of the co-presenters or my colleagues if I missed any of the questions. The chat moves pretty quickly. I've tried to.
It does move pretty quickly. So first of all, Dr. Blackstock, that was brilliant. It was brilliant. I think people are just, again, as Linda said, people are just responding with such positive feedback and just gratitude about being in the presence of this presentation, because it's so, some people are saying it's long overdue. Some people are saying, it's about time, so there's a lot of interest in what you're talking about. And I know this is my own personal question. I know you just talked about motivational interviewing as, an approach that will help, to kind of mitigate some of the things that you talked about. But what strategies do you think you would, recommend for people personally to kind of think about, like, so how am I responsible or part of this? How am I maybe contributing to some of the barriers that might be existing for the clients that I'm seeing?
Yeah, no, that's incredible. Yeah, that's really important because, the work needs to be done at many different levels, including, the individual level, the interpersonal level, the institutional level. Some of the challenges are implicit bias. I just have to say I'm not like a huge fan of that term because I think bias is bias. There actually isn't a lot of data to support implicit bias trainings being effective, and actually what has been actually seen is that they can actually, by making people aware, people can kind of like overdo it, and things can actually end up being even worse in terms of their interactions with populations that they have a bias towards. But I think, I just think about the work we did at the health department in New York City. I think this is all multi-layered. So we have at the health department, which I left recently, affinity groups or caucus groups, which there's actually a lot of evidence for these, and they're on that racial equity website. Thank you, Stacy, for putting that link in. And so it's an opportunity for people within the groups where they share a shared racial ethnic identity can really talk about like grappling with these issues, because for people of color, in particular, the groups can be obviously support and also a chance for even people of color to interrogate their own biases that they might have or like internalize. But also allow really white people to sort of grapple with the feelings that they are having that are coming up for them, because often people feel a lot of shame and anger and guilt and will feel uncomfortable, expressing that or even talking about that among a more diverse group. So racial affinity groups, they can happen in work settings, they can happen, with your friends. It's really a chance for you to self-interrogate, your complicity in these systems. Right. And your contribution to that, and what needs to happen. So that emotional labor, just to say, needs to happen, in addition to like anti-racist trainings for leadership and all of that.
No, that was helpful. That was really helpful to hear you say that, because I think that really the struggle sometimes is like, where do we go from here, and and what can I do? Because I believe, and I think that most people believe that we want to do the right thing, we want to do the best thing, and sometimes we're not always aware of what that means or how to do that effectively. So I appreciate all of those recommendations.
Yeah, and just to say, it's like longitudinal work, right? These issues are centuries in the making, and we've like inherited them, and they're like in our DNA, whether it's like the trauma that we Black people and other people of color experience, or and also the trauma that white people experience enacting some of this. So we all have work to do.
Right.
Yeah.
Thank you. Pike, did you have anything that you wanted to add or ask or say?
I mean, I think I'm going to be helping guide us to the next portion, but I don't want to close out the discussion before we're done. I mean, I'll say it's a resonant conversation for me. I've lost close people in my life to AIDS denialism, and so I'm intimately familiar with just how devastating that can be, and how hard it is to change people's minds. So I really am so grateful for this conversation and this presentation and this opportunity.
Yeah.
Thank you so much for having me. Thank you.
Thank you so much. It was an honor and a privilege to
because I'm not ready to let you go yet. We're not ready to let you go.
Oh, okay. I'm here. Okay.
So wonderful. I'm not ready to let you go.
Oh.
There's a couple things that you did. We started today by talking about what would motivate people to do something different in their approach. And at least for me, just hearing you motivated me to think about just about how to be different. And then, there's a number of things that you did that made me excited. But one of the things that I wrote down that made me very excited is something that sounded simple, but it was so powerful to me. It's not what's the matter with the person, but it's what matters to the person. And I just felt like when you said that, I was like, so it was such a nice way of really kind of, thinking about how to be different in this work, because it sounds simple, but I think that's a complex thing to really embody. So I just really appreciate you saying something like that I think inspired me. So thank you so much for that.
And I have to say, when I heard someone say that for the first time, because that's not my obviously original thought, I'm sure others of you have heard that, like it also was like kind of like revelatory and kind of like earth shattering for me too. So.
Yeah, good. Thank you for that. Yeah. So I'm going to move it to my colleagues again, or if there's any other final comments or questions from anybody that they want to put in chat.
No, many thanks, many little chats of gratitude, and how this is so timely, if not long overdue. And I think you have motivated a lot of us to understand this perspective and really look at how we do things and change how we do things.
You're so welcome. Thank you again for the invitation. And then just thank you to all the disease intervention specialists for all the work you're doing. Thank you.
Thank you.
So now we're going to take it to the next stage of our program.